that wants to, oh, thank you. My team's a step ahead of me. We'll be recording for anyone that wants to kind of slowly go back through this and take your time with the forms. But we want to say a bit about why we're doing this, 10-minute waiver training. And one is because what we've seen over the last few years is that time is a big barrier to getting a waiver to prescribe buprenorphine. A lot of providers note that it's just hard to get away for 8 hours of training, which was what was originally required, or 24 hours of training for advanced practice providers and nurse practitioners. And so the federal government made some changes in the training requirements last year, I believe. Maybe Dr. Walker can correct me. We're all on COVID time. Everything starts to blend, right? But made an exception for the 8 hours of training for those looking to treat 30 or fewer patients. So there's a number of groups across the country that are now doing much briefer buprenorphine waiver trainings like ourselves. So we'll try to get you through the forms alone in about 10 minutes, if that's all that you can join for. And if you can stay on longer, we will walk through some of the evidence base for some of these medications, and also talk about tips for inductions and then additional supports that we can offer outside of the training. So I'll turn it over to Dr. Walker to say a bit about herself, and then we can get started.
Wonderful. Thank you so much. Okay, so if you have joined since I last mentioned this, I have a website at the very top of this slide, and this isn't the last slide it'll be on, and hopefully the iTeam team can send it out through the chat once more now that more people have joined. But we are going to be accessing this website together, and the first 10 minutes is going to be filling out a form for you to get your exemption license to prescribe buprenorphine. So please have your DEA number as well as your medical license number. So a little bit more about me while we give people some time to get their medical license number, their DEA number, and access that website. My name is Crystal Walker. My background is a physician associate, and that is still how I see patients in practice medicine. But I also have my doctorate. And so in the classroom setting, I'm Dr. Walker. For my patients, I'm PA Walker, and you are welcome to call me either or just Crystal. So I am in Fort Worth, Texas, and I'm the director of the clinical services for our SUDS department for My Health, My Resources of Tarrant County. And we have a really robust program where we have inpatient residential detoxification, intensive residential counseling, your typical 28-day residential program, partial hospitalization programs, intensive outpatient programs, OBOT clinics, outpatient-based opiate treatment programs. So my everyday for the last 7 years has been nothing but treating substance use disorders. So hopefully I can answer any questions or give some insight on some of the more basic questions that are preventing individuals from making that leap to getting their waiver and actually prescribing buprenorphine. So like we said, first 10 minutes is going to be going over these forms. And then the last bit is going to be going over some just highlights of buprenorphine and prescribing buprenorphine. So again, hopefully by now you have accessed this website. And I apologize if I clear my throat or cough. I am on the tail end of recovering from COVID. I was fully vaccinated and I lasted 2.5 years, but it finally got me. So I apologize if that happens a lot. I will mute myself and you guys can take your opportunity to read what's on the slide or look into typing questions or whatnot. So, okay, for accessing the form, you're typically going to be presented with this question first, and it's going to tell you to have your DEA number, your state medical license number. Now, the third item you may or may not have, and that is okay. And that is your training certificate, your 8 hours for MDs, DOs, and the 8 hours plus additional 16 hours, 2 certificates for NPs, PAs, APPs in general. So next slide, you're going to, or the next area you're going to go to is going to be checking your waiver eligibility. So this system is going to check for you if you are eligible. So there may be individuals on here who, let's say you are a resident and you are an MD or a DO, but you're practicing under the facility's DEA number. Unfortunately, those individuals aren't eligible because you have to have your own personal assigned to you medical license and DEA number in order for this to work. So this will easily check for you. So if you're not sure and you're just putting something in that you think will work, the system's really good about knowing if you are going to be eligible or not. So then the next slide, once you input that information, or the next page, I should say, when you're online, is going to be these two questions. Now, this is kind of where it's nuanced and it gets a little complicated. For the vast majority of individuals on here, you're going to answer no to both of these questions. And some of you may only have one of these questions on here. But the first one is indicating if you are a board certified addiction medicine or addiction psychiatry individual. If you are board certified in either one of those, your first year, you can actually prescribe to up to 100 instead of the 30 limit. And then the second one is that you provide medication assisted treatment in a qualified practice setting. Now, the majority of you probably don't meet that. So most of you are going to answer no to both of these. However, just so you have this as a reference, who is a qualified practice setting? Typically, these are going to be practice settings that are geared towards the treatment of substance use disorders. They specialize in it. And so these are the detailed criteria. If you would like to take the time afterwards to read through each of these to see if you qualified, you are more than welcome to do so. But for now, we're going to assume everyone is answering no to both of these questions. And when you answer no to both of these questions, you will receive another prompt. Now, if you have your training certificate, if you have taken the 8 hours, or you've taken the 8 hours and the 16 hours, and you have your certificate that you can upload and put all of the details in, then you can put the 30 level with training. If you don't, choose the with exemption. With exemption means that you're using that exemption from April 2021 that Health and Human Services released, and you're saying, I want to get my waiver even though I haven't taken the training yet. So once you choose that one, you can hit next and it'll take you to the next page. For most everyone, this should be auto filled out. If it's not, that is okay. You can go ahead and take the time to type in your name, your information, etc. Now, the next area, item number 2, 3, 4, and 5 for most everyone, is very important. So to break it down, for most of you, you are just going to use the address that's already on your current DEA licensure. If you don't know what that address is, it really isn't massively important as long as it is a verifiable address with the DEA and the state medical board. It can be your home address, it can be where you practice. Most of the time it's where people practice. Now, where it gets incredibly sticky and nuanced is if you are going to keep under your license buprenorphine in your facility. I am going to recommend that for now, that's probably not going to be the case for the majority of you because there is a lot of red tape that goes with that. So if you ever work somewhere where you're going to have the medication under your name stored in that facility, you need to make sure that that address lines up with the address where the medication is stored. For those of you who are not doing that, which I'm going to assume is the vast majority, then it doesn't really matter as long as it's not a PO box. Put your address in there. Now, the email address is the primary way that SAMHSA is going to communicate you. It's actually the only way I have ever seen them communicate. So do not put an address that you're not going to have access to in 3 months, 6 months. Do not put an email address that you don't check very often, or that has a massive spam filter that's going to block all of their correspondence. So use a really, really good email address that they know that they can get in touch with you with, because all of their correspondence is going to be through email. Now, after you fill out that, this should already be grayed out and checked for you. Number 6, which is the purpose of notification. If you notice that you have new notification to treat up to 100 patients checked, that means that you selected on that first page where you're indicating those yes or no's to those first 2 questions. The way you answer those first 2 questions is what auto populates here. And unfortunately, you can't change it from here. So if you see the wrong one selected, you need to go back and choose the proper yes and no to those first 2 questions that were on the previous web page. And you can use the back button to do that. So hopefully everyone has the appropriate one grayed out. A new notification to treat up to 30 clients is most likely what's going to be for everyone. Now, you do have the ability to check the new notification with the intent to immediately treat one person. So yes, you're applying for a waiver to treat 30 individuals at one time. But if you have a person that needs a prescription today, you can actually click this and write that for one person. Now, if you need to write for more than that, you're either going to have to submit additional applications, or you're going to have to wait until you get verification that your 30 licensure has gone through. Now, the next one is going to be number 7, which is that you're stating that you are only going to prescribe scheduled 3, 4, or 5 controlled substances, that you are allowed to prescribe those, and you're only going to prescribe it for the maintenance and detoxification treatment for substance use disorders. And that's a lot of words, but essentially what it boils down to is this licensure is for prescribing buprenorphine for opiate use disorder. It is not for methadone. It is only for schedules 3, 4, or 5, and it's not for other conditions. This isn't for prescribing buprenorphine for pain. It's for substance use treatment only. And that's what you're certifying to there. And then number 8, you're going to choose, if you do not have the training, you're going to choose that you're doing the exemption. It may already be checked for you. If it's not, go ahead and check that red line that states that you're doing it based on the exemption. Now, if you're doing it and you've indicated that you have the training or that you meet one of those other qualifications, then you're going to have to prove that here. You're going to have to prove where you took your training or where you got your board certification, and indicate all of that. And potentially there will be a space for you to upload those certificates. And if there's not, there will be a follow-up email where SAMHSA will ask specifically for those certifications. So if you're doing the exemption, all you have to choose is that first box that says you're doing the exemption for 30 people only. For APPs, you may see a little bit of a different screen, and you want to certify what you are. Are you a nurse practitioner or a physician assistant, or are you a clinical nurse specialist, etc.? And you also need to indicate that you are licensed, because every state differs on who is able to prescribe controlled substances. And so you want to make sure that you're able to, and click that at the end as well. For APPs who have a supervisory or a collaborating physician, you will then need to put in their information as well, including their phone number and their DEA number. Now, this is the collaborating or supervisory physician's information, not your own. So make sure that you're putting in the correct information. And it gets asked a lot on, do they need to be actively prescribing buprenorphine in order for me to put their information here? What it's asking for is their DEA number, not their X number. And the way the legislation states is that as long as they meet the qualifications, they have an active medical license, they have an active DEA number where they're able to prescribe scheduled 3, 4, or 5, then even if they're not actively prescribing, they can still be your supervisory or collaborating physician. And then you're going to certify that.
Dr. Walker, I'm so sorry. Yes. Could I just interrupt for one quick question that's coming in the chat? I think it maybe was pertaining to the last screen.
Yes.
Dr. Hudson was asking, What if we practice in multiple settings? Primary is the hospital, but I also work in an FQHC where I would like to be able to do this. It asks if this location is an FQHC. Answer is no for this primary location. Can I still use the waiver at my secondary location?
That is a fantastic question. Wonderful. And the answer is yes. So what I would recommend is when you're initially doing this, put the address of the FQHC. And what you can do is once you get your license, you will be able to go back to this exact same website that we're accessing. And at the top right, there will be a little area where you can do settings and you can change your personal information. You can add as many practice locations as you need to once you get your X number. So each individual only gets one X number. That is what it's assigned to. So if you have multiple DEA numbers, for instance, the VA has their own DEA number that they want you to use typically. And then if you have one at a private practice, you'll have a different DEA number. Your X number that you're going to get through your waiver is just going to be the first letter. So typical DEA numbers are 2 letters and then a string of numbers. So MW87653. It's going to give you a new number that's XW87653. So the DEA number that you use as your primary, especially if it's not necessarily like locked into a certain location that you can move with, is typically the one that individuals go with. But no matter which one you go with, you will be able to add as many practice addresses later once you get your X number through the settings section. Hopefully that wasn't too confusing. But I do know that they encourage, if you're in a federally qualified health center, to use that one as your primary because of numerous things such as funding and where they push extra money to go to for the treatment of substance use disorders. So I think there is one other question. I'm happy to take that right now if you would like to unmute yourself.
Deepa Mittal, did you have a question?
Yeah, actually what happened was I was not able to follow in the initial screen. So I'm kind of like very lost in the right now because I'm not able to follow the instruction because I think it went too fast for me. I'm going to have to do it some other time, or maybe somebody can send us the recording.
Yeah, absolutely. The recording will be available and I can try to carve out some time at the very end to also assist you if you would
No,
like.
actually I have to leave now. So I'm going to be joining.
Okay. All right. Well, absolutely. We'll have the recording available for everybody. Okay. So moving on, we are almost at the end now. So you're going to certify that you have the capacity, and then you're also going to certify your patient load. So here is where things are going to differ a little bit for some of you at number 9. For some, it's going to separate it out into 9B and 10. And for others, it's going to look like 10A. And the numbering might be a little off, but it all should say about the same things. And essentially what you're certifying is that you're not going to exceed the 30 patients. So if you're doing this registration under the exemption, so under the exemption, you will always be at 30. There is not an ability to move up to the next category under the exemption. So you will eventually have to get the 8-hour training or the 8 and the 16-hour training if you need to move up, if you don't meet one of those qualifications that we talked about earlier, which is fine. It's absolutely okay. Most individuals don't prescribe to more than 30 people because the key word is at one time, that you're not going to exceed 30 patients at one time. So if you write 30 one-week prescriptions in 1 week, you can then write for 30 new people. Granted, 90% of people don't practice that way. They're going to want to have individuals on maintenance, but I know a lot of places like emergency departments and things like that, where you're only seeing people in a snippet of time, and you may see a ton of people in a month. That's why it's 30 at one time, not 30 in a year or 30 in a month. It's while that prescription is active. And then you're going to certify that you're going to keep up with it and that you're not going to go over that amount. Now, after a year, if you have done the training and you are submitting your training certificate today, after a year, you can go in and increase your limit up to 100. If you're working under the exemption, however, in a year, you can't go up to 100. It doesn't count towards the year under the training that you can move up. Hopefully that makes sense. Then you're going to decide if you want your name and your primary practice address released on the SAMHSA treatment locator website. Many individuals choose to not do this in the beginning because they don't want to feel overwhelmed or bombarded by cold calls and things like that. But the benefit of doing it is that it shows who has areas of providers that are waivered and what areas don't have waivered providers, and where trainings need to be targeted at and things like that. So it does help research, it helps with funding, and it helps just helping other providers locate for transfers and referrals. And I've been published on this website for a very, very, very long time. And I think since 2016, I may have gotten 3 cold calls, and that's it. Like, this isn't super widely used by patients. It's more used by the treatment networks themselves. But this is not pressure to click yes or no. You make that decision on your own and decide what's best for you. And the good thing is you can always change it later if you want to. If you want your name added, all you have to do is message them. If you want it taken off, all you have to do is message them or change it in your personal settings. And then you can identify if you want the things that are listed here, the long-acting injectable naltrexone, long-acting injectable buprenorphine, or long-acting implantable buprenorphine, which I'm not sure why it's still on there because that was recently taken off of the market, but I know that they're trying to bring back a new one. So maybe that's why it's still there. So you are able to choose which of those you want published, all or none. And then once you sign your name, once you type your name and you type your DEA number again, that is your electronic signature, and then you submit, and then you should get a screen that says that you have successfully submitted. Now, because of the exemption that occurred in April 2021, there is still a little bit of confusion amongst people filling out this form. That's why we wanted to walk everyone through it if we could, to help answer those nuanced questions. But you still might get an email. Again, use an email that is good, that is contactable, because they will immediately reach out to you and say, hey, did you mean to do the exemption? Do you have training? Do you want to submit the training? Or are you applying for the exemption waiver? I know many people who have received an email like this, and all you have to do is simply reply with what you want. If you want the exemption because you have not done the training, that's perfectly acceptable. A quick reply back and they process your application really fast. Okay, so I'll take a pause here. This lecture is going to be an hour long because we want to give you guys CME, and I want to go over just a couple of things about how to write a prescription essentially, and maybe a little bit of history. But I'll take a pause before we get into that and open it up for any other questions. Is anybody else having any issues with submitting it? Do you have any other questions? So far, you guys have asked excellent questions.
I think there's another one here in the chat. It was that the system was not recognizing their address, which has been on their DEA for years. How do they address this?
I have never had somebody ask me that before. Well, first I would make sure that it's in a format that's recognizable. So for instance, I know some individuals, let's say their address is 121 County Road 4130, but it doesn't recognize County Road. It only recognizes CR or something of that nature. So make sure you try a couple of different formats to make sure that it's not just like a computer lining up glitch issue. And if you try all of that and you've exhausted all of the different formatted ways that your address can be, then I would probably directly reach out to SAMHSA and ask them. And we, of course, can make sure that you have that information if you don't have it already. And then I also see in the at one time is the prescription time frame, and that is a question. And yes, that is correct. So active prescriptions. So if you write a prescription for 30 days, then you have, let's talk about it in these terms. So let's say you have 30 slots. You have 30 dedicated slots that you can write for. If you write a 30-day prescription, that slot is taken for the next 30 days, and you can't fill it again until that 30 days is up. So if you've written on May 1st, 30 prescriptions for 30 days, you can't write another prescription until 30 days after. But if you're in the emergency department and you're only writing 3 or 4 or 5 day prescriptions, and you're not planning on following up with them on maintenance, you're transferring them to another facility for maintenance, then that slot is filled up once that 4-day prescription is over. So it's based on the active prescription. And one thing you do want to be mindful of is if you are doing maintenance and you write a 30-day prescription and you're at your limit, you have 30 patients, and someone, let's say, doesn't follow up and you immediately fill their slot, and then 4 or 5 days later they come back, you need to be prepared for that if you have committed to treating them long term. So I always like to give myself, and I tell my colleagues to give themselves a little bit of a cushion, so that you have maybe 1 or 2 slots open at all times, so that you don't ever go over that. But I'll tell you this, the vast majority of people do not write at the upper limit of their training, of their licensure. So it's pretty rare to have to try to find other individuals to make up for those slots. Okay. And can you see your active prescriptions in PAP per provider, or what is the easiest way to track this? You have a couple of options on tracking your prescriptions. A lot of electronic health records can have a way to query what all your active prescriptions are at the time. And then you can break it down to, let me see all of my active buprenorphine prescriptions. Even my very, very archaic EMR has that ability. If for some reason you don't have that ability, because I actually started practicing when we were still on paper charts before we had an electronic medical record. And we had a secured Excel spreadsheet that the MA took care of to track all of the providers' active prescriptions at that time. So get with your IT department to check that. I find that the PDMPs are a little, I don't want to say unreliable, but they can sometimes be behind a little bit. So I don't always see my most recent prescription, especially if it's a really short prescription, and it can take sometimes the pharmacies or something electronically a little while to update that. So I don't want to rely on that when I've seen gaps of 3-4 weeks, a month, sometimes with my prescription showing up. Okay. Those were all fantastic questions. I will happily take more at the end. Let's go through a couple of these things because I actually think some of the other questions that are being asked will be answered in this last half of the presentation. So I do want to just tell you guys a little bit about the timeline of why we're having to do this. So it actually dates further back than this timeline. It dates all the way back to 1914 when the Harrison's Narcotic Tax Act came out, that essentially there was a line in there that said that physicians cannot prescribe narcotics outside of their practice, outside of practicing medicine. You cannot prescribe narcotics. And they did not view substance use disorders as a medical issue. So substance use disorders have been siloed by these acts. And the Tax Act got essentially gobbled up by the Controlled Substance Act. So it kept very similar wording that essentially said, if you're treating a substance use disorder, that's different than treating any other medical condition. So if you want to write for buprenorphine or a Butrans patch for pain, you don't need an X-Waiver. You can just write that because it's for pain. But if it's for a substance use disorder, you have to be specially trained with a specially license that's tracked by the DEA. And that's because of all of this legislation. And that is why when the press release came out in April 2021, that you can get an exemption and not have to do that 8-hour training course, it didn't do away with the legislation. We would have to have completely new legislation so that we wouldn't need X waivers or X numbers, and we wouldn't have to go through this process of filling out this form online. And of course, there are individuals that are pushing for that, but it hasn't happened yet. So that's why we still have to go through these processes. And in order to treat more than 30, you still have to get that training, because in order to do away with it, we would have to have a major act of legislation like noted here. So these are the two, or this is the main act that we discuss when we're talking about buprenorphine prescriptions, and that's the Data 2000 Act. And that I briefly mentioned earlier on the form, because it does have you click that to indicate that you're aware of it, is that you can only prescribe FDA approved medications for the treatment of opiate use disorder that are scheduled 3, 4, or 5. So essentially what that means is if there is a medication that is being used, quote, off label, and it's a controlled substance, this isn't going to cover you for writing for that, because the FDA hasn't approved at this time anything other than buprenorphine that meets this category, and only special formulations of buprenorphine. Sublingual or the long-acting injectable buprenorphine products are indicated for substance use disorder, whereas the transdermal patch I mentioned earlier that goes by the brand name Butrans, that is not indicated for the treatment of substance use disorder. So you shouldn't ever write for that underneath this license, because it's not technically FDA approved for the treatment of opiate use disorders. So those are the like crazy nuances of all of these legislations and the acts regarding prescribing buprenorphine. And we have gone through the NOI. That's what we just filled out together, was your notification of intent with SAMHSA, who will forward it to the DEA, and you will receive a new DEA license that has both your normal DEA number on it and your new X number on it. Now, you can, if you get the training or you're at one of those specially qualified centers, go up to 100. Or if you get the training and you practice a year at 30 and you practice a year at 100 and you're at one of those qualified settings, you can go all the way up to 275 patients at one time. But there's a little extra that goes with that, which is yearly tracking of your prescriptions on a month-to-month basis. So if you have questions about that, I can answer them essentially offline or afterwards, because that's going to apply to very few people. Okay, you want to keep a log of your patients either manually or through your electronic health record systems. Check with your IT department, your electronic health records, to see, do they have the ability to query that, or is there another staff member like a nurse or an MA that can be given this task of keeping up with the active buprenorphine prescriptions that are under your DEA number. So what is the entire reason why we're doing this? We're all aware of it. It is because of the increased death rates, the overdose rates, the poisoning rates of individuals in this country is skyrocketing, and it continues to skyrocket, and the pandemic hasn't helped. But there have been numerous studies that look at treatment. And if you use a medication such as methadone, buprenorphine, or naltrexone, the overdose mortality risk, or the mortality risk in general of individuals with substance use disorder, dramatically goes down and is almost that of the general population. So these medications are literally life-saving medications based on all of these studies and all of this scientific evidence. Another really good study that I like to point out is that so many individuals, when they start treating substance use disorder, they expect a 100% perfection from that patient. I've given you a prescription for buprenorphine. I never expect another urine drug screen to have opiates on it. You need to be perfect and come to all of your appointments. It's kind of the pain management contract mindset that there's no room for slip ups, there's no room for error. And what I really want to point out is that substance use is like a lot of chronic disease processes. When you write a diabetic for their first prescription of insulin, you don't drop them as a patient the first time their blood sugar is 300. You don't discharge them from the clinic or say, you can't have any more insulin because you ate an entire box of Little Debbie's. No, because we know that this is a chronic illness that has ups and downs. And we want to make sure that they stay engaged in treatment. And there's ways to mitigate riskier behaviors, such as, okay, instead of giving them a 30-day supply, maybe only give them a 7-day supply, or maybe bump up their counseling requirements, or give them wraparound services to figure out what's causing these returns to use, so substances, to help them along that pathway, just like we would send a diabetic to a dietitian to help figure out what's going on to get them back on tracks, because sometimes they need more than just the prescription. So I want you to be aware of that. And a lot of studies have indicated that. And these are a couple of them that show the longer someone is in treatment, the less and less substances they use. So only 50% in the study had negative urine drug screens at the beginning, but by the end, it was all the way up to 80% or more having negative urine drug screens after a year in treatment. So keep trucking along. It's a little bit different. Sometimes positive urine drug screens are expected and should be used as a tool, not a punishment device. So how do you start somebody on buprenorphine? One of the main things that we need to learn about is withdrawal symptoms. And one of the most widely used tools is called a COWS, or a clinical opiate withdrawal scale. And here's an example. It's widely available on the internet, and a lot of these are available on most major electronic health record systems as well. So why do you need to know one of these scales? Well, it is because the action of buprenorphine is only a partial agonist. And as a partial agonist, it has a higher affinity to the receptor than the full agonists do. Full agonists meaning methadone, heroin, hydrocodone, all of the full acting opiates have a little bit of a weaker affinity. So if you've just taken 10 hydrocodone pills and all of your receptors are saturated, and you take buprenorphine, that top line on this graph, you're going to be suddenly within 30 minutes dramatically drop down to the plateau level of the partial agonist buprenorphine. We call this precipitated withdrawal because instead of allowing the full agonist to naturally leave the body over the course of 12 hours or 6 hours, or depending on if it's a short acting or a long acting, and in the case of methadone, more like 36 hours, then starting the buprenorphine when they're in active withdrawal, you run the risk of precipitated withdrawal. And it is more painful than naturally occurring withdrawal. So you want to wait until they're either a CAL score of 8 to 13. And there's some nuances to that. There's a lot of protocols around that say, okay, if it's a simple short acting like heroin or hydrocodone, use 8. But if it has something that's a stronger affinity like fentanyl, or longer acting like methadone, maybe wait until 13. If you need more information on that, I am going to tell you where to get more training and where to reach out for individuals. But typically these are going to be home inductions. And home inductions, the individual's gonna know when they're in withdrawal. You can tell them, you can show them a copy of a COWS, or what is also called a SOWS, a subjective opiate withdrawal scale, that's really easy for a patient to read and go through and say, okay, once you're in moderate withdrawal, you can take your first dose. Your first dose is typically going to be 2 to 4 milligrams, and then every 2 or 4 hours, take another dose until your withdrawal symptoms are better. And typically that max dose per 24 hours on those first couple of days is going to be 16 milligrams. So let's say you have a patient who takes 2 milligrams, then in 2 hours, another 2, then 2 hours, another 2, then in 2 hours, another 2, and then they finally feel okay. So their first day dose is 8 milligrams, 2, 4, 6, 8. So on day 2, they're going to wake up and take a full 8 milligrams. They don't have to divide it up anymore. So whatever that first day total is, whether it's 2 milligrams or all the way up to 16 milligrams, they're going to wake up on day 2 and take that. And typically on day 2 is when you want a nurse or a phone call visit to check up on them, because some people get scared and they aren't in withdrawal yet, or maybe they took a long acting and they haven't even started the buprenorphine. That's also important to know, to answer any questions or calm any fears about starting it. So that 24-hour, 48-hour initial phone call follow-up is really important. And then once they're over the withdrawal, which is typically the first 3 days, then you go into maintenance management, which is you're not really looking at withdrawal symptoms. You're looking more at cravings now. Are their cravings controlled? And one thing that is really interesting and kind of counterintuitive for a lot of practitioners is, let's say that they get through withdrawals on only 4 milligrams and they're like, nope, I want to stay on 4 milligrams. But a week later, they have a positive urine drug screen and you talk to them. They're like, I don't know why I just used, it was there. That might actually be an indication that you need to go up on the dosage, not go down or discharge them, because they may not be as fully covered as you think they are. So there's multiple studies dating from 1998 to 2020 looking at this. And what it looks at is, what is the proper dosing? And they take mainly 3 main categories. One is the self-reported craving reduction from the patient, which in the study in the top left indicated between 4 and 16 milligrams were pretty equivocal over the course of 16 weeks. They all reported similar craving reductions. But if you look at the urine drug screens, it was almost a linear correlation between the dose and individuals with positive urine drug screens. So sometimes they may report, I don't have any cravings, but they continue to use anyway. And that's very important to distinguish between and look at both of those things as reasons to potentially adjust their dose if needed. And then the third thing is, are they remaining engaged? Are they actually coming to the facility, remaining engaged? And one of the big studies that looked at this was tapering them off of buprenorphine really early on at the 4-week mark. So doing a really short-term treatment, essentially the traditional detox, then abstinence only, versus maintenance therapy. And inevitably, individuals on maintenance stay engaged with their treatment for much longer. In fact, this study was really eye-opening because by the time that 14, 15 weeks rolled around, less than 10% of the individuals on placebo actually remained in the study. So almost everyone had dropped out, potentially returning to use when they were trying abstinence only. So this is a quick example. Again, these are examples, 2 different examples of how you could write for buprenorphine for an induction. One is where you can send 2 different prescriptions and do a little bit longer of a follow-up. So you use the 2 milligrams as your initial induction on day 1, and then once they're a little bit more stabilized, they can move to the 8 milligrams. Most generics, both sublingual tablets and sublingual strips, come in 2 doses, 2s and 8s. It is FDA recommended not to cut them. So we are going to talk about using 2s and 8s only as a combination on getting someone started. Or you can write a single prescription for a shorter period of time of just 2 milligrams and give them significantly more. Again, it's best practice to follow up in about 24 hours to make sure they were able to start and to see if there were any issues along the way and adjust from there. And going back to the original statement of the prescription, you really shouldn't overlap. In fact, buprenorphine is so highly regulated, most pharmacies should not give or approve a refill before 3 days until the end of their last prescription. And so you definitely want to make sure you're not giving a 30-day supply as your first prescription, because if you do, and you say you write them for 30 days of 4 milligrams a day, but then they start having massive cravings, you might get stuck in a rock and a hard place with not being able to adjust that medication appropriately. So typically for the first few visits, you want them to be shorter, so that you can make sure that they're on the proper dose before giving them those bigger prescriptions. So these are 2 examples of a way to do that. Now, a lot of you have asked for resources and how you might be able to get your training, the 8 hours or the 8 plus 16 hours. And the best resource that I have is pcssnow.org. And they have multiple resources. Number 1, they have links to self-paced, online only, 8-hour and the 16-hour trainings that you can easily sign up for free, as well as a lot of other educational resources, little short modules that you can take. And they have mentoring. So if you have someone in the area that you want to connect with that is an expert, you can ask them so that you can have more of a hand-holding experience of them walking you through maybe your first prescriptions or things like that. And they also have a really good message board that you do have to sign up for and you do have to show credentials for, so that only qualified medical professionals are talking on this board and it's not bombarded by random people from the internet. And so once you sign up for that, you can search the message boards for questions that may have already been asked, and you can read through what's already there or even ask new questions if you don't want to go through the mentoring route. And then there is also a lot of concern about individuals getting a buprenorphine waiver and not being able to do maintenance or not being able to refer if they have a particularly difficult case. So if you don't know your local resources, I want you to get familiar with something called OSAR, OSAR. There are multiple regions in Texas that have a dedicated individual for outreach, screening, assessment, and referrals for substance use disorder. That's what OSAR stands for. So you can look up your local OSAR who can give you a ton of referrals and recommendations. And if you can't find that, or if that doesn't work well for you for something in person, there is a virtual option with the Be Well Texas Clinic that you can sign up for, and it is all virtual and all over the state of Texas, regardless of where they're located. These individuals can sign up through this website or through that phone number. Okay, so I know that we got a little bit of a late start, so there's not a ton of room left for questions, but I'm going to turn it over to Dr. Lindsay to go over just a little bit more options for you guys, because there are a ton of resources out there. So take it away.
Yeah, if you just want to advance one slide, I'll just say a bit about Project Echo and then we'll wrap up. We want to be respectful of everyone's time. And you'll notice we also dropped a survey link in the chat, so you can just tell us if this information was helpful, what other resources you need. But we just wanted to mention, beyond our brief time together today, we have a whole Echo community of practice. If you're not familiar with Project Echo, it's an international learning community model. We meet over the lunch hour via Zoom, and we have 5 programs operating currently. We have one that focuses on medications for substance use disorders that Dr. Walker is also a part of. We have a harm reduction echo. We have an echo that's specific to treating opioid use disorder in hospital settings. We have another echo that focuses more on systems level challenges for those of you that are maybe in leadership. And I'm probably missing one. We have a big echo portfolio, but we wanted to make you aware of them. Thank you. Oh, and our recovery support services echo. How could I forget? For those of you that are maybe using peers with your services, but just know that these are available to all of you. They are free. We offer free CME and CNE for every session. We're dropping some links in the chat if you'd like to register, but no need to worry and do that quickly. We'll also be sending that around in the post training email, so you'll have access to all these registration pages. But we wanted everyone to know that there's kind of this whole community to support you as you start prescribing. So we don't expect by any means that everyone is going to feel perfectly comfortable after an hour. We recognize we're just scratching the surface, and for those of you that are especially just getting your waiver with this process, so just know that this is in place for us to help you. So all of this information will be available in your post-session email. Anything else you'd like to mention as we wrap up, Dr. Walker?
I do not have anything else to mention. So if you guys are pressed for time, it is exactly 4 o'clock on mine. So this is the end of the session, but I do notice a couple of questions in the chat. So if you guys have the time, I can answer a couple of these questions and stay on maybe an additional 3 to 4 minutes just to go over this. But feel free to log off. My feelings